12 years, initially on metformin, but later on, it was also started on page. And he was diagnosed with hypertension for the past 6 years, but there was not on any medication. And he was also called for ischemic heart disease for the past 2 years. Currently, he presented with 2 weeks stroke, decided anterior chest pain, which was typical, and then which stayed for almost 30 minutes to 1 hour. And he was initially admitted at Ababa hospital for 2 weeks, and later referred for angiography. He was already started on medical management, and currently in presentation he still complains of angina chest pain, which stays for almost 30 minutes and enough, which is worse on site and also on personal activities. Otherwise, there was no other complaint. Vital signs on admission. It was normal. BP was 110/70. Pulse rate was 80 to maximum 90. The maintenance is side pressure. And it was after chest was clear. This one understood side. There was no signs of failure. There was no pregnant finding on other systems. Troponin determined 3 times here. It was negative. We sent for high sensitivity yesterday, but still pending. Otherwise, it's admitted for elective angiography. Cardiac was also complicated. So, yeah, he's already on as resource to start on aspirin, propofol, atorvastatin milligram, metoprolol milligram. Enalapril was initially started, but it continued after it was having dry cough, and he already took heparin. He's only on 50 stocks now. He's on morphine TIR and bisacodyl. Doesn't need any dialysis.
For nitrates, because it was restricted.
Yeah, we sent that prescription, but we couldn't find any nitroglycerin. We were searching for it for the pharmacy. But currently, the pain is somehow better. It's
Troponin is not great at that thing.
was determined 3 times here in the emergency state. It was negative. We sent for high sensitivity.
Thank you, Dr. Rama. No admissions. Coming to Sunday night, last night's duty team. So critical care units, CCU, and ICU. Oh, the eight side. And cases. Okay. The Saturday night team count completed. I guess if that is the morning session, we can proceed to our update lecture. Today's update lecture will be given by Dr. Tedla on time in range as a metric for diabetic management.
We can't hear you.
Hi. I'm sorry. The next one. Okay. I apologize for those of you who are online. Our mic has been muted so far. It is done by mistake, not intentional. Now you're online with us. It was audio and video, I believe. Right. So, as we have said earlier on, intensive treatment of diabetes, tight control of hemoglobin A1C was proven to be beneficial in the DCCT trial. Unfortunately, in another trial, for instance, the big trial that has shown that tight glycemic control may not be as effective as it is used to be in the DCCT outcome. A core trial has shown that individuals who have got tight glycemic control have got higher mortality. So what is this discrepancy due to? DCCT tells us that hemoglobin A1C of tight control, glycemic control of tight nature is beneficial, but the ACCORD trial is the opposite. When we try to tightly control the glycemic status, mortality increased. Why is this? So it is from this that people have started thinking of, could there be any other factor that determine the outcome of a patient? Is it only the tight glycemic control that we need? Should we go beyond that? That is the concept behind developing something different than hemoglobin A1C. So,
Just screen.
the screen. So that now, after this, people have looked to some factors such as glycemic excursions. And it's found to be that glycemic excursion, glucose excursion, the ups and downs of glucose beyond hemoglobin A1C was associated with a number of complications of diabetes. And tissue damage is directly related with glycemic ups and downs. This is also found to be as a result of the oxidative stress that is induced in the cellular structures, particularly in the mitochondria of a cell during the hyperglycemic states. And this glycemic excursion induces a lot of oxidative stress, and that ultimately results in complications of diabetes as time goes on. So it's not only the ultimate sum total of readings that we have by way of hemoglobin A1C, but the day-to-day glycemic excursion has a lot of association with outcomes of patients' long-term complications. And this glycemic excursion is also found to be very important in neuronal development and neuronal function, and particularly in the evolving developing neurons in children, young people, where the neurons are developing. Then glycemic excursion significantly affects their neuronal development and function. So we have to look at glycemic excursion in the management of diabetes, not only the hemoglobin A1C sum total that we get in 2 or 3 months time. So the other thing is hemoglobin A1C does not address a short-term change in the glycemic state. What happens today, what happens next week cannot be seen on the hemoglobin A1C that you are going to find in 3 months time. So the short-term ups and downs, the hyperglycemias and the hypoglycemias that we get in diabetes is not reflected in the hemoglobin A1C. Acute complications are also major hindrances in glycemic management, because when hypoglycemias and hyperglycemic episodes intervene in between glycemic control, then dosage titrations, patient confidence on the management, psychological effect of the patient, psychological effect on the family of the young diabetics is a huge burden in diabetes optimization, the management optimization. And this ultimately affects quality of life, both physically and psychologically. So then people started to look at self-monitoring of blood glucose and continuous glucose monitoring, or CGM. Self-monitoring of blood glucose, SMBG, is a long known parameter in glycemic management. It's a fundamental component of management of diabetes, particularly in type 1 diabetics and type 2 diabetics on insulin therapy. But self-monitoring of blood glucose is a intermittent capillary blood test, so it has got limitations. It has got limitations because it shows only a fragment part of the glycemic state by the time the patient measures it. It does not tell anything in between. Asymptomatic periods may not be picked by self-monitoring of blood glucose because patients either would monitor their blood glucose on a fixed time schedule, be it once a day, twice a day, 4 times a day, or when they are symptomatic. In a person on whom glycemic management or monitoring is done, let us say 5 times or 4 times a day, 6 hourly, let's say. Anything in between that, unless symptomatic, is not measured. So with self-monitoring of blood glucose, intervening episodes of hyper and hypoglycemia are not picked. Meter accuracy is another issue in self-monitoring of blood glucose. The glucometers that we use at a global level, not only in Ethiopia, at a global level, have got a huge limitation. One study has collected 18 different marketed blood glucose meters in Europe, and their association with the standard of glycemic measurement has got a very huge difference. So reliability of blood glucose monitors are always a question at a global level. We also had a small study in Addis, here in Tukurambasa Hospital. We collected 4 different glucometers on market, and we compared them with the standard of care hexokinase method in the laboratory. None of the 4 glucometers that we have seen have met the ISO standard of glucometers, none of them. So this is published some 2 or 3 years ago, 23 years ago. So this is not a problem only at a global level, it's a problem that we have here. Even the problem could be even worse in our settings because we don't have standards of importing meters. Once they're in market and authorized for marketing, we bring them in. I don't think that there is any authority that looks after them, the accuracy of them, and how long we should use it, how to recalibrate it if problems occur. So the problem could be even worse with us. This is an example of a difference between self-monitored blood glucose and a continuous glucose monitor. The dotted points that you see here these are, by the way, 3 different individuals with the same hemoglobin A1C. Look at the blood glucose pattern in these 3 individuals. Their A1C is the same. But in this individual with a red bar, with a red line, the hemoglobin, the blood glucose, this is an average glycemic profile. The blood glucose is significantly on the higher end, at the other time on the lower level. So you cannot predict when these individuals go high, when they go low. Look at the second patient with a blue line. A little better than the first one, but still there is a huge fluctuation. The light, blue color, light green. The light green is the bar for a normal target range, by the way. Anything from that green box is out of the normal range. It's only the third patient, represented by the yellow line, that is within the range. Mind, after 3 months, all of these individuals have got the same hemoglobin A1C. If these individuals have monitored their blood glucose every 6 hours, or 4 or 5 times a day, these are the dotted points. Here, the glucose is within the range. At another point, the glucose is within the range. Do you see the pointer over there? Zaga makan pointer. With the traditional you see, this is the normal box. The box is the normal range between 70 and 180. It's accepted normal glucose at an average. So these individuals, when they monitor their blood glucose, everything seems to be lying within the same target range. But when self-monitored blood glucose is tested, you can see here this individual has got hypoglycemia, there's significant hyperglycemia, at another point within the range, at another point slightly above the range. So this is a 24 hours glycemic excursion when continuous glucose monitoring is employed. So self-monitored blood glucose is not truly reliable indicator of a blood glucose excursion. What about continuous glucose monitoring? As the name implies, continuous glucose monitoring monitors, records blood glucose 24 hours a day. A sensor is applied under the skin and it reads a blood glucose in the interstitial space. And we shall see the components of the self-monitored blood glucose, continuous glucose monitor devices on subsequent slides, but it continuously does it. Data of this monitoring can be seen in real time. Patient can see it in real time when it occurs. And from these continuous glucose monitoring devices, a concept called time in range is generated. Time in range is the amount of time that the individual remains within the range that's acceptable, within the range that is considered to be associated with little complications of diabetes. So that is the concept of time in range that is generated after the introduction of the CDM devices. There are different types of CDM devices that we have at hand on the market these days. And there are two in category. One is called professional CGM. This is not for individual patients' use. Professional CGM is a glucose data is blinded to the patient. Although the machine, the device is attached to the patient does not read it. And this is used usually for clinical trials. The other one is personal CGM machines, CGM devices. These are CGM devices that the patient himself or herself access the data of and interpret and act depending on it. This can be done in real time, a continuous reading. It reports to the machine, the sensor reports to the transmitter transmits it to your device or to the cloud. It's stored in the cloud, no problems. You can download and look at it anytime. This is called a real time. A real time means it continuously reads and transmits and give you an alert. Or it can be intermittently scanned. You can intermittently scan your machine, your device, and see your blood glucose. And this intermittent reading is called flash glucose monitoring. Currently available CGM machines are real-time and intermittent scan systems. They are able to report several glucose variables. They are called the metrics. We shall see the different metrics that a CGM device can report and can be seen on it. So does CGM effectively overcome the barriers that we see in hemoglobin A1C? The answer is yes, it does, because it gives a more comprehensive glucose control picture, and it provides a broad spectrum of glucose management metrics that we shall see. There are 10 metrics, internationally accepted metrics. There are 10 in number, and they can report on 10 of these numbers at a reliable figure. The available glucose CGM devices are of different brands, but the difference between the brands is one on the site where you apply it. Most of them are applied on the arms and some are applied on the abdomen. So the site of application is one of the differences, not a major difference. And sensor replacement time is very different. Some sensors should be replaced in 1 week time, in 7 days time. Other sensors should be replaced in 90 days time, 3 months. So the sensor replacement time is different between different brands. Some may give you special features, may compile, put statistics, additional statistics and data for you if you wish to know that. But that is not very important for the day-to-day patient management for the patient purpose. But for study purposes, for the clinicians' use, it might compile additional data that you demand from them. The price tag is very different, hugely different. And actually what limits the use of CGM at a global level these days is its price. But from time to time, the price is coming down. As the technology advances, as the use is familiarized at a global level, as the market expands, similar to any other technology, like your smartphone, the price is going to come down. It's already coming down, but it's going to come down further and expected to come down significantly, because still at the current standing price, the prices are a little hindering its use. And some CGM machines or devices require professionals to install it. Others can be installed by the patient at home and removed and replaced by the patient at home. This is what it looks like, some of the examples that we have. Freestyle Libre is the first, and it is the cheapest actually. It has got different generations. So as you can see here, the round bit here is, this is the sensor and the transmitter, and that is the handheld reading machine or the receiving machine. And the other one is Dexon G6 sensor. This is one of the most expensive. And the Guardian also is a little expensive, and it requires health professionals' assistance for its installation. There are different others too, but these are commonly used ones. These are the components of the CGM. As you can see, these are the whole thing that you get with your CGM machine or device when you buy them or when you're provided. This is a sensor pack. This is a sensor that is in here. So this sensor is contained in here, and this is the sensor applicator. This sensor is applied by this one, and that's the distant reader. As you can see here, this is a human tissue, that is the skin, that's the interstitium, and that's the capillary. Physiologically, we know that blood glucose is at an equilibrium between the capillary and the interstitium. That is the whole concept of that. It is in equilibrium between the capillary and the interstitium, means whatever you read in the interstitium is whatever you read in the capillaries. So reading it here is similar to reading it in the capillaries. So your sensor is applied in here. This is the glucose sensor. It's a needle inserted into the interstitial space, and this is the transmitter. It takes whatever the sensor reads, it receives, and it transmits it to your receiver. So this is the whole thing that you have in the CDM device components.
Uses infrared.
It uses Bluetooth by and large, but different technologies can be used, but it transmits generally by Bluetooth technology. So as we have said, CGM benefits include setting therapeutic target at an appropriate level with little risk. It also helps you to evaluate the management regimens that you're using, how effective it is, the risks that are associated with the regimen, particularly hypoglycemic risks. It also helps physicians to adjust the doses. As I have said earlier on, this is the same graph, similar graph that we have said earlier on. These highs are the undetected hypoglycemia in this individual, undetected hyperglycemia. So there are several undetected hyperglycemias, and the first bit is the long arrow is undetected hypoglycemia. But when you use self-monitored 6-hourly blood glucose, you don't pick this. So this is picked only by the CGM apparatus. Now, globally, CGM is rapidly replacing self-monitored blood glucose. This is because it frees individuals from daily repeated needle sticks. So individuals, patients, diabetic patients like it. It also overcomes the problem inherent in hemoglobin A1C and self-monitored blood glucose that we have discussed earlier on. Numerous studies have proven that real-time CGM and intermittently scanned CGM in the people with type 1 and diabetes, both in multiple daily insulin injections and continuous subcutaneous insulin infusions. The studies have proved that these are much beneficial than the hemoglobin A1C and self-monitored blood glucose. The use of CGM has gone more than fourfold between the year 2010 and 2018 in Europe. It has gone from 7% to 30% use. So 4 times increase in only 8 years' time. So it is rapidly taking hold. These are all dependent on the 15 years experience of different studies. Before CGM devices are licensed and authorized, 15 years have elapsed in looking at these machines. Different studies have been done over the 15 years period. So now in many countries, CGM is considered to be the standard of care in type 1 diabetics because type 1 diabetics are on insulin. And per the protocol, they are on multiple daily insulin injection or continuous insulin infusion. So it has become an internationally accepted standard of care in type 1 diabetics. Randomized controlled trials have been conducted on several problematic areas of diabetes management in individuals with severe hypoglycemia, with individuals with hypoglycemia unawareness, in individuals on multiple therapy, multiple daily injection therapy, and during pregnancy. All these RCTs have confirmed that self-monitored blood glucose with CGM is as effective as it is expected to be. And cost-wise, it has resulted in a substantial improvement in the cost of diabetes care. It also has changed the quality of life of diabetics. What did we learn from the COVID era on CGM? We have learned quite a lot. During the COVID era, strategies have been coined in diabetes management to minimize patients' attendance in the clinics at a global level. So diabetes service was not compromised during this period in many countries. Patients did not appear in person in the clinics, but individuals did not suffer very much in terms of their glycemic management. This is made possible because of telehealth, and this is made possible because of digital services. So the digital technology and telehealth medicine has improved a lot during this period of COVID. In the absence of routine laboratory hemoglobin A1C, the value of time in range and other CGM device metrics have proven themselves during the COVID period. For instance, in one study from Scotland, this is for in May 2020, in type 1 diabetic individuals. This published data shows that the percentage of time in range over this period increased from 53% to 56% after shielding. Time in range has improved during the COVID period compared to the preceding period. And this has demonstrated associated improvement in glycemic variability, and ultimately the 3 months hemoglobin A1C has improved in these individuals because of use of the CGM. This difference have been revised back for the data before the COVID in 2019. The time of the COVID have been found to be better in terms of overall glycemic control and ultimate hemoglobin A1C and reduction of glycemic variability. So from COVID, we have seen that if properly used, this technology, it improves the glycemic management, it improves the glycemic excursion variabilities, it also improves in the ultimate hemoglobin A1C if used properly, even much better than what it used to be without COVID. Another study that has been reported from Spain on type 1 diabetics, after shielding, elderly people who are at very high risk have been shielded during the COVID era, in the early periods of the COVID era. During this shielding period, time in range has increased in these shielded individuals, high risk individuals. Time in range has improved from 58% to 62%. 58% before COVID, 62% after COVID shielding. Estimated hemoglobin A1C has improved from 7.4% to 7.1%. But the backside of this is this was not so in socially deprived community for obvious reasons. In the socially deprived parts of the community, this improvement have not been seen at a substantial degree. Other studies in people with diabetes have also shown improvement in percentage in time in range in different parts of the Europe during the time of the shielding of COVID. So this allowed many physicians, clinicians, and patients to consult each other via the virtual consultation. The machine reads it, the doctor can access it from the cloud, and the patient can read it at home, take an action on the events that has occurred. Ultimately, consultation can be done virtually. The difference between what we do here and what they do there is the technology, the virtual technology is far advanced, and patients can access appropriate virtual technologies, and the patients can easily consult on video conferencing, video consultation virtually. Otherwise, remote management of the patient is something beneficial when it comes to diabetes. At least as it has been seen here in the diabetes management during the shielding period and the isolation times. By the way, some of this data have been incorporated in the practice guideline of the UK Diabetes Cells program. Post-COVID, as it's expected to be, many appointments will continue to be virtual, remote. So learning from this COVID time era would be very important because it's expected that many things will continue virtual wherever it is applicable. So learning from this and empowering both the healthcare professionals and the patients in the virtual consultation and continuous glucose monitoring wherever it is available would be very important. So what are the whole metrics that are incorporated in the continuous glucose monitoring CGM machines? There are different metrics that are incorporated in this. An international consensus has been established. A consensus group has been established in 2019 on the CGM. It's called the International Consensus on TIR. This international expert group that has been established during this period have looked into the available data, and they have generated 10 reliable metrics that can be used on a CGM device. But for a CGM to be interpretable, to be reliable, the patient has to wear it at least for 14 continuous days. 14 continuous days. And from 24 hours of every day, at least 70% of the time, the meter has to be active. 70% of the 24 hours. The meter can be turned off or may not be read for the rest of the time. But at least 70% of the 24 hours has to be active machine, active device, and that has to go for 14 days. It is only if this long duration of data is collected that a reliable interpretation can be done from the data that is generated from CGM. So various evidences show that TIR is, as a predictive marker of diabetes complication, is reliable. Particularly microvascular from the 15 years data that has been reviewed. Data that is generated from the CGM is associated with a reliable indication of microvascular complications. Macro, we still require a lot of data, but for microvascular complications, if you follow the CGM device data, it has been associated with significant reduction of microvascular complication if a patient achieves a good control in terms of achieving the time in range. Once the patient has been reading, or the machine has been reading for 15 days, the glucose level, a parameter or one of the metrics called ambulatory glucose profile can be generated. A visual profile of a glucose can be generated from that. We shall see what AGP is. So CGM-based clinical target recommendations from the International Consensus on Time in Range has been endorsed by several international renowned professional associations and patient associations. The American Diabetes Association has incorporated it into its standard of practice since 2020. The American Association of Clinical Endocrinologists, the American Association of Diabetes Educators, the American College of Endocrinology, European Association of Study of Diabetics, and a number of others have endorsed CGM as a standard of practice, standard of care. These are the consensus recommendations. Time in range is considered to be a glucose between 70 and 180. That has to be achieved at least for more than 70% of the time. This is what is called a time in range. Time above range, TIR is for above range, TBR is time below range. Time above range is categorized into two. One is a modest hyperglycemia between 180 and 250. That's called level 1 hyperglycemia. And that should not go beyond 6 hours of the 24 hours, 25%. Time above range of level 2, which is greater than 250, should not go beyond 1 hour and 12 minutes, which is less than 5% of the 24 hours. Same time below range is categorized into two. Time below range, level 1 is hypoglycemia between 54 and 70 milligrams per deciliter of blood glucose. That is called level 1 hypoglycemia. That should not be more than 4%. Severe hypoglycemia, significant, clinically significant hypoglycemia is when the blood glucose is less than 54 milligrams per deciliter. That should not go beyond 1%. If you can achieve those figures, this is a consensus recommendation that is aimed to be achieved. If this is achieved, hemoglobin A1C that comes ultimately from it, and the glycemic variability that is of danger to the patient's tissue is avoided by achieving this. As we know, time below range is important because in diabetes management, hypoglycemia is a center point. Avoiding hypoglycemia stands in the center of diabetes management. So avoiding a blood glucose less than 70 or minimizing it, if you cannot avoid, minimizing it to the stated figures is required. But when you opt for a very tight glycemic control, it's unavoidable that you risk hypoglycemia. That's where Cdm device is important. Any hypoglycemia that comes will be corrected immediately by the patient because the patient reads it. An alarm sets off from the machine. So the patient reads it, scans it. I'll show you how that is scanned. Patient scans it from exterior and take a measure. Time above range is also for the same purpose is important, particularly level 2 hyperglycemia is important because if it is not acted upon in time, the risk of diabetic ketoacidosis would be very high because this is primarily now for type 1 diabetics. So DKA is a huge risk when level 2 hyperglycemia is not detected. Level 1 hyperglycemia is a warning point for the patient to take some measures to bring it down. Individualization of targets still works here, like the A1C. For these two, we need to individualize the target of individuals. Individualization is set for pregnant ladies. Individualization is set for individuals who are at high risk because of aging, because of other comorbid conditions or hypoglycemia unawareness. Your target has to be individualized. This individualized target is for pregnant ladies, by the way. The studies have shown that very small proportion of pregnant ladies achieve glycemic targets these days. This is a study that has been earlier studies that have been reported on using real-time CGM. On an average, women spend only 50% of their time with glucose within the recommended target. Only 50% of pregnant ladies. The rest do not achieve their targets. And that improves as time goes on during the course of the pregnancy. Again, in type 2 diabetes also, similar poor control of blood glucose has been demonstrated by studies that have been using continuous glucose monitoring devices. Achieving blood glucose control in the final 3 to 4 weeks of pregnancy would result in a significant outcome difference in the neonate. So if you properly follow the CGM devices and achieve good glycemic control in the last 3 to 4 weeks of pregnancy, neonatal outcomes would improve significantly. The target for a woman who has got type 1 diabetes and pregnant ranges between 63 and 140. The other target was 70 to 180, mind. In pregnant ladies, the target should be between 63 and 140. Keeping blood glucose above 140 to less than 25% is recommended. Anything that goes beyond 140 should not go beyond 25%. For type 2 diabetics and gestational diabetes, the data is very much limited, but similar kind of things are recommended. The data is available for type 1 diabetes, reliable data. For GDM, we don't have strong data yet. And for type 2 diabetes in pregnancy, we don't have strong data yet. but the consensus group recommends similar cut points to be followed. These are different studies. The concept trial is on pregnant ladies that achieve glycemic target. If you can achieve between 5 and 7% improvement in time in range, by the way, bringing blood glucose into the target range in pregnancy is very difficult, even with a CGM. Even with a CGM, this tight control is very difficult. But every 5 to 7% improvement in time in range. For instance, a patient whose time in range is 50%, if you bring it to 55%, you bring about significant change in the outcome of that pregnancy. So every 5 to 7% change, which is between 72 and 100 minutes a day, increases the time in range during the second and third trimester of pregnancy, is significantly associated with outcomes such as low for gestational age, outcomes such as neonatal hypoglycemias, and ICU admission of the neonates. So aim for only 5% improvement in time in range, only 70 minutes of the day, 1 hour and a few minutes. If you can improve to that degree of time in range, you can change the difference in the outcome of the neonate in the pregnant ladies. Even if you are not able to achieve the target, improving some percentage point is very, very crucial in pregnancy. Same holds true in elderly individuals. The time in range is between 70 and 180, but the percentage of time that we require to achieve this is not 70% or above like the rest. In elderly individuals, if you can achieve 70 to 180 milligrams per deciliter for more than 50% of the day, 12 hours of the day, this is a good target for the elderly. This is a good target for individuals who have got hypoglycemia unawareness or severe hypoglycemia episodes. So you go for only 12 hours of the day within that target range. If the remaining goes out of that, provided that the time below range is restricted significantly. The time below range should be restricted significantly because in elderly individuals, hypoglycemia is deleterious than the rest of the age groups. So hypoglycemia has to be significantly reduced to less than 1% in these individuals. You don't have to go beyond below 70 milligrams per deciliter in elderly individuals. Hyperglycemia is tolerable in this age group. You don't very much target the values between 180 and 250. You opt for avoiding values above 250 in these individuals. So if you avoid values above 250 for to less than 10% of the time of the 24 hours, which is about 2 hours and 24 minutes, then these individuals are quite safe in terms of their outcomes. These are summarized metrics that we talked about. The CGM machines can give you all this. One is the standard visualization data called the AGP. We shall see what AGP is. Mean blood glucose is calculated by the machine for you. Hypoglycemia is set at less than 70 milligrams per deciliter for the general purpose. And low and very low hypoglycemia and very low and very high and very high hyperglycemias that I have already told you. And then the time in range is calculated. The time between 70 and 180 is calculated. And glycemic variability is calculated. If the variability is less than 36%, that's acceptable. So the machine tells you how variable this glycemic variability is. If it is kept within that range, this is acceptable. And glucose management indicator is an estimated hemoglobin A1C. You can estimate hemoglobin A1C from 14 days of CGM machine. Reliably estimate that. And that's called GMI, the glucose management index or indicator. And that is a calculated hemoglobin A1C from the CGM machine. And the daily recommended data sufficiency, as I said, is 70% of the 24 hours, at least for 14 continuous days. These are the targets that I have told you in tabulated form. This is another individualized targeting for pregnant and high-risk groups. And using time in range in conjunction with ambulatory glucose monitoring. What is an ambulatory glucose monitoring? An ambulatory glucose monitoring, or an AGP, is the machine calculated profile of the blood glucose. The machine follows it for 14 days or for 7 days, and the profile of the blood glucose is put for you in a graphic form that you can easily visualize. This is the graphic form of it. The one on the other side is the graph that the machine generates for you. Some people call it AGP is the EKG of diabetes because it more or less looks like the EKG of the heart. It tells you the ups and downs. So if Dr. Rufera and his team allows us, we are also having our own EKGs.
Put them on. Of the day.
EKG does not belong to you. That's the point. Right. So this is called the EKG of diabetes. Look at this. This is a bigger picture. It tells you how the glucose variability. This collects the average for this period in time, for instance. It collects several days of this time's blood glucose and puts it at as a mean for that particular time. So it tells us that what the profile of the patient's glucose like from day to day when it's collected to an average. So it tells you as if this glucose change is occurring every day. So it's the collection or a mean of whatever period that you have been following. By looking at that, you can see the profile of the patient's glucose excursion. So this is more or less similar kind of things. Now we have 4 individuals who have got hemoglobin A1C of 8 from a standard laboratory. I shall show you how variable their blood glucose is on the following 4 individuals. This is patient number 1. As you can see, look at the upper panel. The mean blood glucose from CGM in this individual is 195. The estimated blood hemoglobin A1C or the GMI in this individual from the machine is 8.4%. Look at the time in range. It's only 42.2%. This patient is in range. Most of the time, this patient passes in the hyperglycemic range. Level 1 and level 2 hyperglycemia, 57 and 23%. Hypoglycemia is not common in this patient. So this patient is more or less in the hyperglycemic state for most of his time. But the hemoglobin A1C from the laboratory says 8% A1C. But the machine, based on that mean blood glucose of 14 days, says that the A1C in this individual is 8.4. So the machine here underestimates this patient's blood glucose. Hemoglobin A1C does not tell us that this patient stays in hyperglycemic range most and does not have significant hypoglycemia. Look at the next patient. The same hemoglobin A1C, 8% in the laboratory. The same hemoglobin A1C in this machine, the CGM machine, 8.4%. The mean glucose is 195, similar to the first patient. But in this patient, the severe hyperglycemia range is not very significant, but the time in range is much lower than the previous one. The third patient is the same patient with hemoglobin A1C of 8% in the laboratory. The CGM tells us that his mean blood glucose over the period is 156. His estimated hemoglobin A1C is 7%, not 8% that the laboratory tells us. But this 7% is achieved because this patient has been suffering a lot of hypoglycemias. Look at that. Level 1 hypoglycemia is 10%. It should be less than 5% from the guide, less than 4% from the guideline. This individual has a severe, significant hypoglycemia, 4.4%, should not be beyond 1%. This A1C achievement is at the cost of hypoglycemia in this individual. This patient is in target range only for 54% of the time, did not achieve the 70% time in range. But A1C is good, but this is obtained at a cost of hypoglycemia. You wouldn't be able to see this if you do not use this machine. If you use only hemoglobin A1C in the laboratory, you would call this patient a poorly controlled blood glucose target, and you would optimize or increase the treatment target. You would worsen this hypoglycemia there. So this is the advantage. Patient number 4, mean glucose 163. A1C from the machine, the CGM machine, is 7.3. In the laboratory, it is 8%. And this patient does not have significant hypoglycemia. The time in range is much better than the preceding 3 individuals. But this patient's hemoglobin A1C was 7.3% because level 1 hyperglycemia is high in this patient. Level 1 hyperglycemia can be corrected by the patient with some adjustments of the diet and exercise. So these individuals, all of them have got 8% in the laboratory, but the profile is entirely different. The approach to your management is entirely different. For those suffering from repeated hypoglycemia, you address the hypoglycemia. For those suffering severe hyperglycemia, you try to avoid DKA, intervene pharmacologically. For those with modest degree of hyperglycemia, advise your patient to adjust some lifestyles, including diet and exercise. So the approach is entirely different if you have got the profile at hand. So this is what I've said, and this is also a summary of a pictorial summary of the targets. So what about hemoglobin A1C compared to time in range? We've said that hemoglobin A1C misleads us in a number of situations, and population A1C, unfortunately, is very, very different. In the next graph, look at this. This is from NIHANS, the United States data. This is in healthy individuals. Look at the hemoglobin A1C distribution in healthy individuals. In the Black African Americans, the A1C is naturally a little on the higher side without diabetes. In the Hispanics, it is in between, and the whites have got a little lowish hemoglobin A1C, even from the baseline. So hemoglobin A1C is not one and the same for every individual. So should the target be one and the same for every individual? That raises a question. Until that is solved, CGM at least would solve this discrepancies. So this is again advantage of time in range compared to hemoglobin A1C. We repeatedly have said that in the talk. And we call hemoglobin A1C reduction clinically significant if we can achieve 0.4% of hemoglobin A1C. If you can achieve 0.4% up and down of hemoglobin A1C, that is said to be of clinical significance. So any person who has got a 7.7% A1C and 7.4%, the 7.4 have got clinically important, significant impact on the health of the individual. If you bring down a hemoglobin A1C of 8% to 7.5%, you have made a clinically significant reduction in the hemoglobin A1C. So A1C is said to be clinically significant if you bring it down to by 0.4%. Now, time in range percentage. When is it significant? The percentage in time in range, which is of 10% magnitude, if you achieve 10% improvement in time in range, you will improve hemoglobin A1C by 0.5%. So if you bring an individual's target from 60% to 70%, you would achieve a significant, clinically significant change in the hemoglobin A1C. So changing 10% time in range, improving 10% time in range would improve the patient's outcome significantly. 10% is associated with 0.5% hemoglobin in A1C. You can also convert the percentage time in range versus hemoglobin A1C. These are different studies, but generally look at the 70%. These 4 different studies have shown that at 70%, you are close to the target that you are opting for, close to 7% and beyond, below. So if you achieve a 10% time in range, the hemoglobin A1C of that individual is expected to be 9% and beyond. If you can achieve 90% time in range, hemoglobin is about between 5 and 6.5. But generally, 70% achievement would achieve the targets that you go for. So conversion of time in range, TIR, to hemoglobin A1C is based basically on those 4 major clinical trials. So you can achieve a target of 70%, and then you can achieve a good outcome in terms of diabetes. Anything below that is associated with high hemoglobin A1C. Anything above 70% would risk some degree of hypoglycemia. You have to be cautious in that. But the machine will tell you where you have gone wrong. So what is the real-time, the real-world efficacy data? These are all what researchers are telling us. What about the real-world data? Do we have anything in the real world? The European registry has shown us that CGM was used, and its use was associated with a better glycemic outcome and less hypoglycemic risk. In this type 1 diabetes exchange registry, individuals who use CGM would have have been shown to have lower hemoglobin A1C. Another registry review from the Dutch, the German, Austrian, the Swiss, Luxembourg diabetes program has also shown the same CGM initiation lowering hemoglobin A1C. So this is huge registries from different countries, different European countries, and different diabetes registry programs. So looking backward in this registry program, achieving good target in hemoglobin A1C in CGM would achieve a good hemoglobin A1C control, and the outcome from that have been found to be significantly good. The same has been seen in the UK, in the United Kingdom. More than 10,000 individuals have been reviewed in the registry, and the same outcome has been proved to be the case when registry has been reviewed backwards after use of CGM for some time. And people also tried to look at what has occurred in the DCCT trial in years back, decades back for that matter. And this is a review that has been done from the DCCT. In the DCCT, by the way, individuals have been measuring their blood glucose intermittently at least 7 times a day for 6 years of the follow-up time. 7 times a day, post meals 3 times, and bedtime another one. 7 daily records. So this data have been reviewed, reanalyzed, and it was found that 10% improvement in time in range with the current concept of time in range. Albuminuria has reduced by 40%, and retinopathy has reduced by 64% compared to those individuals who did not achieve that target. Same data has been obtained for type 2 diabetes from other studies, and the same reduction has improved the retinopathy prevalence and occurrence of abnormal intimal medial thickness in the carotid artery. Microalbuminuria has improved. So other studies have also been reviewed. Similar kind of findings have been generated from those retrospective reviews of previous big studies. These are the results of diabetes complication associated with time in range. There are different individuals who have tried to look at the diabetes complication compared to time in range. And from all of them, retinopathy, albuminuria, carotid intima media thickness, and painful diabetic polyneuropathy have been reviewed. The hazard ratio for these complications to occur was inversely with the time in range percentage. The better the time in range, the lower the hazard ratio is, the lower the odds ratio is. So these are several studies, and particularly Beck, the first author, is an authority in this area, by the way. Most of the studies that are quoted is from this individual and his team. So these individuals and the rest of the team have looked at several data, and microvascular complication is found to be significantly associated with achieving time in range. So time in range is important in microvascular complications, but for macrovascular complications, the data is not yet very mature. It's not very, very robust. So time in range, or TIR, and the metrics associated with the CGM indicates the day-to-day fluctuation of blood glucose and the day-to-day experience of diabetic individuals living with diabetes. So this is a real-time kind of data, and this is a very reliable, patient-empowering and patient-encouraging kind of approach, because patients are at their own command on their diabetes. You don't tell them after 3 months what has happened and where the errors could have been. The patients themselves look at it and see it and tell you whether they are doing it right or not, and they can correct it in real time. When they found their hypoglycemia, by the way, I don't know how I skipped one of the scanning slides, how a patient scans it. This is how you apply the CGM machine. That is the applicator that I told you earlier on. And with the applicator, you punch it on the skin. The needle goes in and it sticks on the body. That's it. And then with the sensor, with the reader, you read, you scan on it. Or you can do it on your smartphone. You can download the application on the smartphone and read it from the smartphone. You can Bluetooth transmit it to your computer or laptop, or do it on the tablet, whatever smart machine device that you have at hand can be used if it's connected to the clouds. So the data goes to the cloud and comes back. So this is the way a patient follows their blood glucose. So this is a real-time monitoring of their own blood glucose. A real-time decision is made. If a patient checks on it and found it to be hypoglycemia, corrects it. If that was found to be hyperglycemia, and if so modest degree, some physical activities can improve it, or additional dose of insulin can improve it. So patient is empowered in managing their own glucose. So is hemoglobin A1C on the way out? The answer is no. The answer is a big no, because this is only a beginning of an additional armamentarium that we have in diabetes. So we don't push away our old friend, good old friend. Hemoglobin A1C continues to be in action. But it has to be combined with the use of CGM wherever it is possible, because there are a lot of loopholes in hemoglobin A1C measurement. So CGM devices can overcome this problem. So you can use them together, but you don't push away your hemoglobin A1C. But in the long term, as technologies advance in the CGM devices, the prices come down. Patients and healthcare professionals are empowered. It might go out, but for now it does not. Who should be using time in range and CGM? Type 1 diabetic individuals are the ones that are the major candidates. Type 2 diabetic individuals on multiple daily insulin injection are also recommended to be on CGM machines wherever possible. The others is based on the decision of the healthcare provider. If the doctor believes that a patient benefits by monitoring the blood glucose and taking an action on it, then any individual that the doctor thinks would benefit from it can use it. But generally, type 1 diabetics and type 2 diabetics on multiple daily insulin injections are the major targets for now on to use the CGM machine. So the CGM technology is rapidly advancing, as you know. And by measuring glucose levels continuously, understanding an individual's glycemic status becomes more comprehensive. Hemoglobin A1C alone does not provide, but some metrics from the TIR would provide you more realistic picture of the blood glucose. It tells you in real time what the blood glucose is having, and it's a much more positive goal for the patients to strive for. This empowers the patient, encourages the patient to optimally follow their glucoses. It is more accurate measures than hemoglobin A1C for assessing glycemic control, particularly in some individuals where hemoglobin A1C have got a pitfall, such as hemoglobin A1C, hemoglobin abnormalities, anemias, polycythemias, and during the course of pregnancy when the RBC lifespan is very, very short. So in this sort of individuals, it has got a particular benefit. But in general, whenever hemoglobin A1C, particularly in developing countries like ours, where anemia is so prevalent, if the technology allows us, CGM is a very good device to use. Improving time in range can help achieve your hemoglobin A1C target safely. Safely because you don't go blindly to hypoglycemia. You see where hypoglycemia is coming and you correct it. So you can safely achieve your A1C if a patient has got a TIR device that measures the TIR and the fluctuations and the variabilities are detectable. It provides valuable information that hemoglobin A1C does not give you. So it tells you the pattern of blood glucose, like in the AGP that we've said earlier on. The AGP is ambulatory glycemic profile, and it tells you the profile. You see the pattern. After 14 days, you can print out the pattern of the patient's blood glucose, and you pictorially, graphically see it. And it's very easy for you to understand, very easy for you to show to your patient and tell the patient where actions have to be taken. It is very visual. It's a very depictive. So these are all what we've said earlier on. So this is what I have with regards to time and range, continuous glucose monitoring. Although it's a little bit of a horse rush kind of talk, I think you'd have some idea at least what's going on in the rest of the world and what is awaiting you guys once you are out of your training. For us, probably we may not reach using it at a wide scale in this country, but for you guys, the technology is coming. You will be encountering that. Have no doubt that you will be practicing it in your lifetime. Thank you. Questions, comments?
Thank you, Dr. Tedla, for this state-of-the-art lecture on progress on management of diabetes and the development in technology. So CGM is something that is showing us importantly the glycemic variability, as it is stated very well in the lecture. And it is in addition to self-monitoring blood glucose and hemoglobin A1C. So I just wanted to share, I have one patient who is using this Dexcom self-continuous glucose monitoring. She's type 1 diabetes, and she has been using it during pregnancy, and she has a good outcome. Surprisingly, hemoglobin A1C has never gone between 6 to 6.5, and the profiles on diabetes EKG are perfectly well, and she has been showing me this. So this is going to come. It is very expensive. She has to go abroad to do it in Dubai somewhere for annual 6,000 or so. So it is very expensive. So, but it is going to come. So we need to know. It may be even before our time, it may come. Hopefully, to some an increased magnitude.
You are somewhat younger than me.
Yeah.
You have all the right to say that. No, I'm just joking. I mean, this is not the technology far away. The smartphone that we're using now have been a luxury 5 or 6 years ago. Now everybody has got a smartphone. So in 3-4 years' time, this CGM technology could be widely available. I just wanted to tease you out. Otherwise, with regard to the machine uses, I don't know, the lady doesn't need to go to Dubai. It is simple to apply. If she's using the Dexcom, the Dexcom Freestyle Libre is patient applicable, because if she's demonstrated once, the people who are applying it for her wanted it for the business purpose. Otherwise, they could have shown her. And she can buy a year's supply of the Dexcom. By the way, the Dexcom CGM is changed every 14 days, but recent generations might be working longer. Otherwise, it is frequently changed. There is one other CDM device called EverSense that you have to change every 7 days. The price ranges between $160 to $500 a month currently. So 500, the black market are you can imagine what a monthly supply would require these patients. So this patient of you who's
this price for the sensor?
It's for the replaceable sensor. The sensor, the whole pack is bought. The handheld device, the receiver is cheap, and you can do it on your smartphone. The whole price is for the sensor and the transmitter. And that pack is worth between 160 for Freestyle Libre, that's the cheapest, and 500 USD for the other one. The other ones, more expensive one. The Ekg of G6 is one, and the other one is, as I've shown you, the Contour and the EverSense, and all of them are a little expensive. And monthly 500 USD, and that's about 6,000 a year that our brother is telling me. 6,000 a year USD. It is not a cheap price for most Ethiopians. But there are a few. I have a couple of patients who go to the United States. They have got insurances. Actually, one of the patients, I don't know why he has it, because he's taking oral medications. But he always shows me that, oh, my sensor always reads oral medications. You cannot adjust it on the strokes. Why do you continuously monitor the glucose? Doesn't make any sense. I recently have another experience with a patient who has got switch on, switch off. ከዚህ በኋላ ብዙ ላይ ያስፈልጋል።